Good afternoon, all. I am Dr. Jaswansi Darbar, Director, Gujarat State Branch IMA. Today is our first webinar of the series of the 12 webinars in coming year. The first and foremost topic is, because the monsoon is approaching, it will be preparation of pre-monsoon illness. And I am handing over mic to our coordinator, Dr. Kasundra Vasantbhai. Kasundra Vasantbhai, please.
Yes. Very good afternoon, friends. I, Dr. V.B. Kasundra, welcome to all our CGP body of Gujarat State Branch of IMA. It's an immense pleasure to inform friends from today. Our GSB CGP wing start new initiative for education seminar for our general practitioner friend. First, I welcome to our speaker, Dr. Mahadev Desai, Secretary Dr. Mehulbhai Shah, Dr. Dhirenbhai Mehta, Dr. Torawala, Dr. Gadvi sir, and our director, Director of CGP, Dr. Jaswant Singh Darbar, Secretary of CGP, Dr. Vasantbhai Patel, Dr. Bhupendra Bhai, and specific Dr. Ramesh Babu. I ask Darbar sir, please introduce Dr. Ramesh Babu.
Welcome, sir. I have gone through your this profile. My God, lot many degree from BSc, MBBS to PhD and FCGP and all that. I'm not going to narrate all the degrees. He's our Dean of College of GP. He's a B.N. Mehta awardee, and oh my God, almost he has got recipient of 8 state, 7 national and 43 international award in medicine and social service. Such a great man. So I invite him to say a few words. Rusil, unmute कर दें. Sir, unmute. Ramesh Babu, unmute करो.
Am I audible, sir?
Yeah.
Yes.
Good afternoon, all of you, the renowned leaders of Gujarat State. It is my privilege and honor to be a part of this very important program. First of all, let me send my pranams to our beloved leader, Dr. Ketan Desai, sir. And today, I'm very happy to see Dr. Mehul Singh Jadeja, sir, Honorary State President, and Mehul Shah, sir, State Secretary, and Dr. Jaswant Singh Darbar, our Gujarat State CGP Director, and our beloved Dhiren Mehta ji, Giant Secretary of CGP, and other leaders from Gujarat State and CGP. Good afternoon, all of you. It is my privilege, really, since 35 months when the COVID started in our country, being a general practitioner and a leader of IMA Tirupati branch successfully for 3 years, I thought people are unable to come for the personal meetings and started doing the online national and international conferences every month. It is really very hard to work for 40 days to conduct 1 month CME, 1 month conferences within 18 international and national speakers all over the country with different super specialties. And July 2nd, we are going to conduct one more that is on legal, ethical, legal, moral, psychological, and social responsibilities pertaining to the medical profession. This topic has been given by our beloved Honorary Secretary, sir, Dr. Anil, sir, and our beloved leader, sir, Ketan, sir. So they are very much interested to stop the violence against doctors. Before that, we should be very clear and clean from our side, being a practitioner, whether you are a general practitioner or specialty practitioner or super specialty practitioner, you should follow all the legal, ethical responsibilities pertaining to the medical profession. Then I think 50 to 75% problems we can solve our own. There will not be any violence against us. So we strongly believe on that. So renowned speakers will be going to give the lectures on that day. You're all welcome. I request the State Director CGP kindly circulate that news to all the members. As of now, we received around 800 registrations. So in that process, I know how much is important these webinars today, because all the doctors are very busy. They are unable to spend even little time for the personal presence. Occasionally, they may come, but it's very difficult. You know very well, in Tirupati, we have 1,400 members, but for CME, IMA CME, we used to get only 40 members. It's very difficult to get even 40. That is very, very unfortunate, because when doctors have a problem, they will look at the IMA. Before that, you should strengthen our IMA. You should have a good rapport in the society that IMA is very strong and they have a very good support from all the doctors. So if you go and touch any member, they are going to take a severe action. That message should go to the public. For that, the people should come for at least IMA meetings once in a month. But that also very difficult nowadays. It's very sad part of our IMA. Anyway, these webinars are directly going to so many people. And that initiative taken by the Gujarat State CGP is very good. And every month, one hour. I request, it's very hard to organize even for 1 hour. Instead of going for 1 hour, let it be 2 to 3 hours and try to get the credit hours. If we give the credit hours, then the participants will be more number. I request the CGP director, sir, kindly see that it should go for at least 4 to 6 hours, 2 hours. You will get 1 CMA credit point from Gujarat State Medical Council. That is very essential for the participants. I request you, please, in future, you are going to conduct 12 CMA programs. Very good. And try to take the credit point from the Gujarat State. Even 1 credit point, it's going to be a big asset for the big help for our general practitioners. And why I'm telling, because I am getting around 1,200 participants online every conference. They will not go that side or this side. They should be 6 hours. They must be in online 6 hours. Then only we will issue the certificate. So such a stringent rules we have for the webinar. I request you, please try to see that at least 1 credit point, if you give for this one monthly CMS, which we are going to organize, it will definitely help our general practitioners as well as other doctors also. They may come for a little bit interest, and the topics are very good. You know, you all know very well that nowadays it is very easy to get whatever topic in the net. They can just go to Google, and if other medical websites, it's very easy to get the information. So people will think that what is there here, we can go ahead with the internet. So we should avoid that impression, because they should respect our IMA, our CGP, or whatever it is, AMS and other AKSINA Institute, all these things. We have to strengthen our IMA by attending these programs. That message, all members should get it, adopted for this. Then only it will be very successful. I sincerely thank the Dr. Jashwant Singh Darbar sir for repeatedly calling me, even though I'm at Canada now. I came to attend my son's MBA graduation ceremony. He stood first in the Toronto University. So I'll be back on 21st of this month. So it is early morning hours for us, no problem. I sincerely thank all the people for participating in it. Preparing this program is very difficult. The first program is preparing for monsoon illness. Is very, very important topic by Dr. Mahadev Desai, is a senior physician, KD Hospitals, Ahmedabad. And next month, just now I heard from the Dean and Director, sir, that is on second Thursday, 13th July, they are going to have one more pulmonology topic, excellent topic, need of the hour. Sir, it is really a boon for the CGP members in your state. I request you kindly continue this. Whatever support you need from the CGP headquarters, we are there. We have permission for the webinars for every month for more than 3,000 people. And we purchased the webinar from the SVMC Alumni Association, where I am the president for that. So with these few words, I inaugurate this program, and I thank all the organizers for giving this excellent opportunity. Thank you very much, sir.
Sir, thank you and for kind attention. Sir, we have already applied for this credit point in medical council, and we have said that we are going for a 10 to 12 hours webinar throughout year. So kindly sanction the credit point according to it. So we will be definitely going to get credit point, and we'll take note of your point, sir. Thank you. Kasundra, sir.
Excellent. Excellent, sir. Congratulations.
Thank you very much, Dr. Ramesh Babu Sarji, for kind word of the CGP and your suggestion. Now, I introduce our today's speaker. It's my great pleasure to introduce our today's speaker, my friend and my senior colleague, Dr. Mahadev Desai. Presently, sir is working at KD Hospital City Center, Vastrapur, Ahmedabad as a senior consultant physician. He has passed MBS, MD exam from the MS University, Baroda, served at Medical College of Gujarat at Baroda, Surat, and Ahmedabad. Teaching and professional experience of 14 years since law. Honorary editor, Gujarat Medical Journal in 1990 to 2000. Even is awarded for Dr. B.N. Mehta oration by AMA in 2012. And awarded Dr. N.B. Patel and Dr. Rasik Lal Shah oration award by Association of Physicians of Gujarat in 2018. Sir is also a member of RSSDI. Specifically, he take interest in diabetes also. Without wasting our time, I give my mic to Dr. Mahadev Desai. Sir is speaking regarding the preparation for monsoon illness. Sir, over to you.
Hello, good afternoon and welcome to all. First of all, thank you to IMA CGP office bearers, Dr. Mehul sir, Dr. Darbar, Dr. Kasundra sir, and especially to Dr. Ramesh Babu, who is all the way from Canada at the early hours, have remained present and blessed us. I am going to talk about the preparing for the monsoon illnesses. Before we start, let us play that our great thanks and tribute to all the persons who have been helping, like the NDRF team or the volunteers. And I have been told by Dr. Kasundra that IMA Rajkot has also prepared their team for any eventuality that may happen in the medical side for the cyclone Biparjoy. So let's hope that we don't have to rush in for more casualty, but all the same, we salute all the volunteers and the NDRF team, disaster management team, who have been working there for the last couple of days. Coming to the disclaimer, I am a physician and not an infectious specialist. And we know that medical science is ever changing. What I say today is relevant today. Tomorrow, the practice might change because the guidelines might change. And as Dr. Ramesh Babu has rightly said, everything is available on the net. But what is important is how to distill and give it to the right, in proportion for the right audience. So that's what I have done it. I have no conflict of interest as far as the topic is concerned. I'm going to talk in the next 40-45 minutes about the monsoon illnesses, about which are the illnesses, what are the clinical features specifically to be looked for specific diseases, what would be the initial investigations and what would be the later investigations. I'll be touching the management only in a very, very superficial way and specifically for the focus on the OPD basis. We know that we are at the family physicians audience mainly. So I'll be talking mainly about the attending the monsoon illnesses in the OPD setting. So how should medical faculty be prepared for monsoon illnesses? Should we be worried? Surely not, but definitely been something like the pre-monsoon brainstorming as we are doing today. And I always believe that it is the institution of family physicians which are our main first line of defense for all medical illnesses. So it's the family physician's burden or with a lead that picks up any trends which is coming. We know that disease keep on changing year by year and season by season. So it is the family physicians who will be picking up the trends. And for that, all the family physicians are requested that they should be on lookout for the typical and atypical symptoms, and whether there are any other symptoms, like whether this time there are more of respiratory symptoms or more of gastrointestinal symptoms, or are there any hemorrhagic manifestations with the patients, and how are the patients distributed. do they come in clusters or do they come from a particular locality or it is spread across the state or a city? And it's very, very important and pertinent that we keep talking or keeping a dialogue with our pathologists and microbiologists friends, because they will be would be giving us the clue about the diagnosis as well as the resistance of any drug that we might be prescribing otherwise. And so it's better that we start discussing with all our colleagues with the very few cases of the illness in this season with all, and maybe the IM headquarters will take the lead for dissemination of the knowledge about a particular outbreak which might be coming. And again, I also request all the family physicians and all practitioners for that matter that we should not be prescribing antibiotics and shades of steroids without diagnosis. If the diagnosis is confirmed and if we need NSAIDs for a chikungunya, that's a different story. But otherwise, just like that, without diagnosing a condition, we should be avoiding prescribing any of this. And we know that antibiotics are used, overused, and abused. And most of the illnesses, even in monsoon-related illnesses, are viral and where antibiotics play hardly any role. So why do we get more infectious diseases in monsoon? It's all because there is definite increased susceptibility in the rainy season because of the high moisture content and the microorganisms density as well as survival increases. There is widespread waterlogging, floods. There is change in the salinity of the soil and water, and which makes the fertile ground for the mosquitoes, flies, and all the ticks. Then there is also change in the food habit, with the change of weather. So all in all, we have contaminated water, food, air, and there are enough mosquitoes all around. So it's better that we take note of this and start preparing ourselves. So what are the common illnesses prevalent in the monsoon? I have given a list of diseases, but it's not complete. Mainly, we are dealing with malaria, influenza, and all upper respiratory infections, dengue fever, chikungunya fever, then host of gastrointestinal infections like acute gastroenteritis, cholera, typhoid, viral hepatitis. Leptospirosis is not as common as it is thought, especially in certain foci. Pneumonia also could be a dreaded illness. Then common skin infections and epidemics of viral conjunctivitis. It is more important, other than the list of common diseases, that we must keep an eye on the life-threatening complications of these diseases or uncommon but critical illnesses. Like whenever the patient presents with just fever, but whether there is any sign of meningitis, encephalitis, or encephalopathy, either because of the cerebral malaria or because of the typhoid, or it's a disease by itself, then is there any evidence of myocarditis? We have seen with COVID that in many patients with myocarditis, septicemia, then either any evidence of acute respiratory distress syndrome or multi-organ failure. Then is the patient showing some signs of hemorrhagic fevers in the form of widespread bleeding or the manifestations on the skin? And are there any evidence of tick-borne diseases which are again keep coming sporadically? So this is what we should begin with. And for that, we need to see what are the common clinical symptoms and signs that we encounter. Then we'll be talking about the uncommon symptoms and signs. So obviously, fever remains the most important symptom presenting in the OPD, whether it's at family practitioner's level or the consultant's levels in this season. Patients also will have body ache, headache, myalgia. We should be looking for whether the headache is generalized headache or whether it's a retroorbital headache, or whether the myalgia also pertains to the paraspinal muscles of the calf muscles, the importance of which I'll be telling a little later. Whether the patients have findings of the upper respiratory infections in the form of running nose, cold, or cough, or sore throat, or is the patient complaining of abdominal pain, nausea, vomiting? Are there diarrhea? Does the patient complain of joint pain of more than one joint, and whether there are not only pain but the swelling also? So these obviously are the common symptoms, and we are all familiar with these. Issue is about the uncommon symptoms. At any given time, if the patient has one of these complaints, it should be on high alert. We should be looking for whether there is any history of loss of consciousness, even if it is transient, in this illness, because we know that cerebral malaria is something which may start with the profound loss of consciousness. Then are there any convulsions? Is there any breathlessness which could herald the beginning of, say, pneumonia because of the COVID or even H1N1, then chest pain because indicating pneumonia. Are there any bleeding manifestations in the form of petechiae, or whether there is systemic bleeding in the form of hematuria or hemoptysis or hematemesis? Is there a conjunctival congestion? I would strongly suggest that at least have a look. It's not that all these things require a lot of time. No. If we have structured way of asking the questions and the examination, it shouldn't take more than 5 minutes for all these to finish. Then are there any muscle tenderness? Is there an eschar? It's something that indicative of crop typhus. I'll be touching again. A question about the urine output in the previous 24 hours. On examination, are there any liver, spleen, or lymph nodes enlargement? All these will give a long way to indicate about the possible diagnosis and the line of investigation. But what is important, as our Professor Ramesh Babu has also rightly said, that we should be worrying about the medical legal aspects. So I strongly suggest that we must keep a record of at least whatever we see, even in the OPD, that we must maintain our findings, our investigations, and if you have advice for hospitalization, keep a note of it, and if required, we can get the consent of the patient or not against the hospitalization. It's very, very important. What sticks in the court of law is only our findings, written notes, and nothing verbal. So it's very important that we start keeping the notes of our findings. Then the first and foremost in monsoon is the patient who comes with fever. Low-grade fever generally not alarming, and patient may or may not visit us and might go with only the symptomatic treatment. But if the fever, which is say 100 plus, is something that we must start analyzing the moment patient comes with fever. My first question or the first other symptoms that we should be looking for, that are there any localizing symptoms and signs? What I mean by localizing symptoms and signs means, is the symptoms of fever pertaining to any particular system or particular part of the body? If the patient has very high-grade fever, we always think of whether it's an upper respiratory infections in the form of either the influenza or COVID, or whether it's a severe disease like dengue or malaria or leptospirosis. So first and foremost thing, if the patient has running nose, sneezing, sore throat, obviously we are dealing with one of the influenza illnesses, influenza or influenza-like illnesses. So it's very important to correlate the symptoms of fever with other symptoms. If there are localizing symptoms like dysuria, patient has bending neck, increased frequency backache, and then obviously we should be focusing more on the ruling out of urinary tract infection. Likewise, if the patient has ear discharge, patients who come with multiple joint pain coming up over a period of few hours with swollen joints, we know these days is mainly chikungunya. We do get arthralgia and dengue, or 1 or 2 joint mild sinusitis in dengue, but it's mainly chikungunya which will present with multiple joint pains over a period of few hours to a day. So if there are localizing signs, well, we are probably on a step more better ground than if it is generalized. So influenza, COVID-19, sinusitis, pneumonia, urinary tract infection, or chikungunya are the diseases which would have some localizing signs or symptoms. As against that, if the patient is only fever, headache, body ache, myalgia, weakness, anorexia, these are not pointing to any particular system or particular organ. So our diagnostic possibility remains malaria, dengue, typhoid, leptospirosis, and many other several illnesses. So that is the first thing that we should be looking for. Are there any localizing signs or symptoms, or there are no localizing signs? Then another important thing in the history that we must look for the tempo of the fever. Usually, most of the illnesses, the fever would subside in a matter of 3 or 4 days. If the fever persists beyond 3 or 4 days, it's definitely cause of concern and a case for investigation. But and whether the fever comes with rise-up, whether fever comes at a particular time. If a patient says that his fever is at Monday 3 p.m. and again Wednesday 3 p.m., I may almost thought that he is suffering from Vivax malaria, because that's the only one which comes with clockwise regularity. If the patient has clockwise regularity, it's most likely to be a Vivax malaria. Falciparum usually does not follow a clockwise regularity because of the irregular physiognomy. That is what the parasite's development is. But fever is important. If the fever keeps on rising day after day and not having much symptoms, we must keep in mind conditions like typhoid fever, where the fever remains high grade from day 1 or day 2. and whether the other members are affected, whether the neighbors are affected, whether the society as a whole is affected, the people working in the same place are affected, is another question you would be asking, just to see whether it's an isolated case or there are cluster of febrile illnesses or it is the beginning of an outbreak. So again, we have to be on toes for that part of the symptoms of fever and other illnesses, and whether patient has been exposed to gathering or crowd or water park or rainy floods. That's very important. If the patient had been to water park or was in the, he was congested and he was in the held up in the rainy floods, then we know that it could be leptospirosis. So that's very, very important. Not to forget, in individual cases, whether the patient has any comorbid conditions. As we have seen in COVID pandemic, that patients having conditions are the ones who are more likely to be hospitalized and more likely to have multiple complications. So comorbid conditions are a must, whether it's patient has diabetes, chronic obstructive pulmonary disease, ischemic heart disease, heart failure, or chronic liver disease. We must keep this at the back of the mind for any patients having these diseases. It's an already a high-risk patient. Whether the patient has undergone post-transplant or whether he is on immunosuppressant drugs, whether the patient has in drug hypersensitivity or is a case of G6PD, because we are tempted to use Primaquine more often in patients this season. So we should be knowing whether the patient has G6PD deficiency, or we know our locality, some of the communities have high prevalence of G6PD. So again, if the patient comes with a particular from the community, we should be on alert for a possibility of G6PD. And always, when the patient comes with on the second or third day, or patient has already received treatment at home or from other practitioners, we must keep a note of it. And same is with the alternative therapy. We know that we have got many crossopathies and many mixopathies, and people would keep on taking drugs because of their publicity is probably more than what we can do. We cannot advertise, and the other ones are free to do. So people will keep many drugs, and we know the drug-drug interactions are plenty. So that's what's very important in the history. On clinical examinations, the vital signs must be mentioned, recorded on the first time and every time that we see the patient on the second day or third follow-up day. So conventionally, the temperature, pulse, blood pressure, respirations were the vital signs. But I would add it in OPD setting, we must add oximetry and then the blood sugar also, because this gives a lot of information about the patient's stability and the hemodynamic stability. So not only the temperature, pulse, blood pressure, respiration, but oximetry in each and every patient that we see, and the random blood sugar at least once should be recorded on the first visit. Then when we examine the patients, and the very first thing is the very look of it. After years of seeing the patient, we can make out whether the patient looks sick, whether the patient looks toxic, and irrespective of whether we can describe the very feeling of it, the intuition tells us that this patient is very sick. If you see a patient of typhoid or if you see a patient of septicemia, I don't think you need to describe how it looks. He looks toxic. As against that, the patient of malaria would not, or chikungunya would not be looking toxic, even if they have many complaints. So the very look is very important, and we make a note of it, whether he looks sick. Then what is the sclera? Is there any doubt of jaundice? Because jaundice can be there as a part of vital hepatitis. Jaundice can be there even because of the hemolysis. So keep a look of sclera. Then conjunctiva, as it is shown in the lower panel, the conjunctival, what is called congestion or suffusion is the word used. Conjunctival suffusion is something where the patient has painless redness of the eye. And usually unilateral, it can be bilateral. So when a patient has conjunctival suffusion, it could be indicative of disease like leptospirosis, which if we pick up early and treat, probably we avoid the complications which usually start in the second week. So conjunctival suffusion, I would strongly suggest to look for. So is the sclera for jaundice, and skin for purpuric spots. Then whether there is synovitis. When we examine the patients, right, we might look for this tenderness, especially in the calf and paraspinal muscles, which is again the more commonly prevalent in the conditions like leptospirosis. When it comes to, before that, if you can see this something like this, whenever there is a suspicion of dengue, we can do the tourniquet test. Tourniquet test is we just apply, tie the trigonometer cuff over this upper arm and inflate between the systolic and blood pressure for 5 minutes, and then see in an area of 1 square each, that is mentioned here, area of 1 square each. If you get more than 20 petechial spots, then it is an indication of tourniquet stage positive, which is an indication of vascular fragility. It is not an indication of thrombocytopenia. It indicates vascular fragility, and that is something that we should be looking for in the coming days for the danger for red signals for dengue. So look for petechi. If there are few, at least do the tourniquet test. It takes only 2 or 3 minutes or 5 minutes maximum, but we can get a host of information. Likewise, if you can see something like this, not that we expect it more often, but if you see something like this, some rash which looks like a butt of a cigarette, that is called eschar, then it is indicative of the rickettsial disease like Kraft typhus. Synovitis, we know very much. So this is what we look for in the general examination: jaundice, lymphadenopathy, any conjunctival suffusions, any petechial spot, the very look of it, any synovitis or any specific rashes. Then systemic examinations, we'll be looking for whether there is a liver, spleen, tenderness in the abdomen, especially in dengue. We'll get some tenderness because of the fluid collected rapidly around the gallbladder. Then whether the chest shows any signs of pneumonia, consolidation, or the bilateral findings. Then cardiovascular system might we pick up something like murmur, third, fourth sound, or a tachycardial rub. And if there is tired of fever, headache, and vomiting, at least we should be looking for signs of meningitis. And whether there are any localizing neurological signs indicative of more serious disease, something like brain abscess. Then, as I said earlier, we should be looking for specifically the signs of dengue and malaria, which are the two which has got a very high mortality if not treated and promptly and diagnosed promptly. So this is what we'll be sparing 1 or 2 minutes for the dengue as well as malaria. They are very important. We know that dengue is no longer now described as dengue fever, then hemorrhagic 1, hemorrhagic 2, and dengue shock syndrome. That is already gone for last 15 years, almost 15 years. In 2009, WHO and CDC came out with a revised dengue classification, where the dengue is divided into dengue with or without warning signs and severe dengue. So patients who present with fever and any of the nausea, vomiting, myalgia, joint pain, right, then he could have possible dengue. And if he gets thrombocytopenia on examination, that becomes almost like a dengue. And in that case, we should be looking for any warning signs. The warning signs are whether the patient has abdominal pain with high-grade fever and possible dengue, or persistent vomiting, clinical fluid accumulation in the form of ascites or edema or signs of pleural effusion, whether there is a bleeding, mucosal bleed, or whether the patient has lethargy or restlessness. They are indicative of decreased poor perfusion to the capillaries and hypoxia. So restlessness is something we must pick up at the earliest. If the liver is enlarged beyond 2 centimeters, whether the laboratory is suggestive of hemo concentration, that is rise in the hemoglobin beyond 20%, or fall in the platelet count on a day-to-day basis. We'll be coming about the investigations in a minute's time. Then the severe dengue is something where the patient has the evidence of severe plasma leakage, severe hemorrhage, or severe organ damage. What we mean by severe plasma leakage is the patient has shock, patient presents with hypotension, tachycardia, barely palpable pulse, and which is not corrected by giving the IV fluid, or there is already overfluid and patient is in respiratory distress, or patient has frank bleeding, whether it is epistaxis or hematuria or hematemesis, and on a clinical parameters like the liver is enlarged and there is a SGOT and SGPT are more than 1,000, or patient has impaired consciousness, or whether the other organs are involved. These are the indications for severe dengue, and they are the ones which need to be hospitalized beyond doubt. Then, as far as the malaria is concerned, we know that WHO has defined the severe malaria as anyone where high levels of parasitemia beyond 5%, or there is any organ dysfunction. So what do we mean by severe malaria? If the patient has loss of consciousness without any other identifiable cause beyond half an hour with a high-grade fever, or if the patient's hemoglobin is less than 5 gram in the children or less than 7 gram in adults, or patient has evidence of acute kidney injury or hemoglobinuria, red color urine. Then if the hemoglobin, the blood sugars are less than 40 milligrams, patient has severe persistent hypotension beyond less than 70 millimeters of mercury, patient is in ARDS, patient has severe acidosis, or patient has the evidence of disseminated intravascular coagulation. The last two are obviously out of investigation we can think of. So these are all the important conditions we keep in mind, mainly pointing to the malaria and the dengue. But investigations are for all the diseases that we have at the back of the mind, leptospirosis, dengue, or influenza-like illnesses, typhoid, and other diseases we'll be talking about. But there is no rule of thumb for recommendations. We have to individualize the case for ordering the investigations. I would suggest that at least on the day one, if there is no clear-cut localizing signs like the upper respiratory infections, which we may not go for any investigations, the family practitioners are in the advantage that they can see the patients more than once, even once morning, once evening, or every day. So they may refrain from investigations on day one if it's a clear-cut case of influenza-like illness. But if at all we have to investigate, get CBC, peripheral smear, platelet, PSR, urine analysis, SGPT, creatinine, and random blood sugar. There is no point in asking for CRP or D-dimer or IL-6 or anything on day one. In fact, there have been abuse or over-investigations, increasing the cost of the therapy. But what is important is that when we are suspecting at least something like dengue or COVID illnesses, we may have to repeat the investigations. And depending on the case, if the platelets are rapidly falling, we might need it daily, or at times we even order platelets morning and evening too. Say, likewise, if we need, we may go for the investigation like sodium, potassium. If there is a tendency for bleeding or pathology or thrombocytopenia on the investigations, we might ask for the bleeding parameters like prothrombin time or activated sparking thromboplastin time. CRP only when we are suspecting COVID and we have to take the call for whether this is also in moderate and we need to hospitalize, then we go for something like CRP. Bilirubin only when there is a hemolysis and we have to find out whether it is, jaundice, whether it is hemolysis or it is hepatitis. Bilirubin, particularly direct and indirect with the enzyme levels, will differentiate between the hemolytic jaundice and the hepatitis. CPK, D-dimer, they are all required very sparingly. Imaging studies, again, on case-to-case basis, we might need X-ray chest if we are suspecting pneumonia. Then sonography is my investigation of choice for suspected typhoid fever. Again, we'll be talking a little later. Then CT scan, HRCT may be required when we are again more when we are dealing with the influenza-like illness and the patient has restlessness or hypoxia not corrected by the routine oxygen therapy. We might need high-flow nasal cannula therapy or hospitalizations. We go for this. Then specific test depends on what we are suspecting. It's not possible and not cost-effective to investigate on everything. What we suspect will decide which investigation we should go for, whether we should ask for the test for malaria, or dengue, or chikungunya, influenza, or SARS-CoV test, or any test for typhoid, viral fever, cholera, or leptospirosis. So it all depends on what test we need to do for what is in our mind. If it is malaria, obviously the time-tested gold standard is thick and thin smear. And if we get thick smear, we can pick up the disease early, but we may not be able to say which parasite is causing the fever. So thin smear is the gold standard between far less than stain, and we can pick up Vivex, falciparum, or both. And QBC method is now not routinely used, but it came with a big bang. And definitely the Buffy coat if the blood is kept in a tube, then Buffy coat is one where there is maximum concentration of the parasite. And which, if we see under specific microscope, we might be able to see whether the patient has malaria, and we can differentiate between Vivex and falciparum too. But what is most commonly used is the rapid diagnostic test for the malaria. And nowadays we have got the test which can pick up falciparum as well as the pan-LDH that picks up the Plasmodium vivax and falciparum both in a particular case. For dengue, we obviously go for the first is the CBC, and if there is leukopenia with activated lymphocytes, and if the hemoglobin is on the higher side, or if we are lucky to have the patient's previous report of hemoglobin of say 10 or 11, now it is 13, or we go for the hemoglobin on the next 10, it has increased. There is an evidence of hemoconcentration. Always go for SGPT because SGPT has got a prognostic value. Patient of dengue with a high SGPT on day 1 or day 3 is likely to have more complications than the person who has normal SGPT value. And on day 1, the test for dengue would be after CBC would be the dengue either serology in the form of dengue NS1 antigen and antibodies to IgM, IgG, or dengue viral injection by RT-PCR. Now we have got RT-PCR available, which is combo RT-PCR, which can pick up dengue as well as chikungunya, and where we can get a diagnosis on the first day itself about the possible dengue or definite dengue. And if the patient has IgG more than the IgM on day 1 or the first few days, we might be dealing with the secondary dengue because patient who has got the dengue first time, IgG will take at least a week's time to appear unless the patient already had dengue in the initial years. Then if we are suspecting bleeding tendency, we need to go for the blood test. It's very, very important to know how to interpret the serology of the dengue. And as I said, the viremia, the dengue virus would be there in the system for first 1 to 5 days, not more than 5 days. So if we have to do RT-PCR, we should be doing in the first week itself. NS1 antigen also should be ordered only in the first 4 or 5 days. The IgM will start appearing around 4 or 5th day. The IgG would appear after 7 days. If the patient had earlier dengue infections by another fever, we might get IgM and IgG positive on the day 1 or day 2. So patient who has got IgM and IgG both positive, we should be on toes because patient who has secondary dengue infection, that means dengue infection coming out for the second time, is more likely to have complications. And this is the very, very important one slide for the whole course of dengue. Dengue is a very, very mathematical model. If the patient comes on the day 1, we know how he is going to behave. If he comes on the day 3 or 4 and a very high grade fever, I am on toes. So if the patient is the first few days, at least first 3 days, very, very unlikely that he is going to the complications, except for probably the dehydration. So this is very, very important. If the patient, the most important time for dengue to be worried about is on day 4 or 5 or 6, 7, or on the day the patient's fever has subsided and his platelet counts at the lowest compared to the earlier days. The day the platelet counts are the lowest or on the lower side and the fever has gone, that 24 to 48 hours are very, very important. During that time, if the patient has abdominal pain, vomiting, restlessness, hypotension, we are surely dealing with dengue hemorrhagic fever or dengue pox syndrome. And this is the time we should be very, very aggressive in the treatment. But for that, if the patient's fever has reduced without antibiotic, platelets are lower, it's going to recover. The next round of investigation would give us the idea that platelet has gone up from say 30,000 to now 40,000, enough to know that yes, platelet turnaround is very important. If the platelet has taken U-turn, we are happy that probably nothing would happen, and all that is required is that make sure that the patient does not go into the fluid overload because of the fluid that is all absorbed will come to the circulation. So that is the only precautions we take in the recovery period if the patient has smoothly past the critical period. So it's very, very important. For leptospirosis, may not be very common in some of the areas, but patients in the rainy seasons, those who are exposed to the flood water, we know that all the rodents, whether it is rat, cat, dog, all the urine excreta would be mixed with the water, and if have an abraded skin or by inhalation, the leptospira, which is a bacterial infection, spirochetal infections can enter. And in the first week, we have a high-grade fever, body ache, myalgia, conjunctival suffusion, especially calf tenderness and paraspinal muscle tenderness. The diagnostic test is the gold standard, is microscopic agglutinous test called MET, but it's not available everywhere. If there are leptospirosis epidemics, the government would set up the laboratory for that. Luckily, we have it one in Ahmedabad and one in Surat. But if it is not available, we can go for the ELISA test for IgM antibodies, and we can pick up the leptospirosis right in the first period itself. The blood culture for leptospirosis is available, but it's a slow-growing organism. So at the critical time of illness, we may not have the diagnosis at hand. So either MET or ELISA for antibodies should be looked for. Coming to typhoid, which is again an illness which is very, very important this monsoon, please do not go for the viral Vidal test. The reflex patient would come out with or would insist for the Vidal test, but for the first 7 days, we do not expect Vidal test to be positive, number one. So is typhoid dot. And the second part is there are so many false positive tests. So it is better that we do not go for the Vidal test, and that's why in the list of investigation it is struck, right? If we have CBC on the very first day, we might get leukopenia with monocytosis and eosinopenia. If the eosinophy is 0 or 1%, right? And if the clinical feature is such as a high-grade fever, toxic flu, we might get a little spleen or liver or a dry cough, or then a strong suspicion of typhoid fever. I would suggest blood culture and sonography of the abdomen. USG abdomen is a very, very important investigation, and a good sonologist can pick up the thickening of the right iliac fossa, the ascending colon, where we expect the right, or we might get even the ulcers, we might get the lymph nodes, we might get even hepatosplenomegaly. So typhoid diagnosis, I would rely more on the sonologist or the blood culture. The advantage of blood culture is we can get the exact whether it is typhoid or paratyphoid, and we can also get the drug sensitivity. But after CBC, my choice of investigation would be sonography, and certainly not Vidal. I haven't done Vidal for years now, I can say with confidence. Then amongst all these cases, what are the signs of danger or red flags, or where we have to think of calling the 108 or asking the patient for hospitalization? Patients with a fever for more than 7 days, patients with persistent abdominal pain or vomiting or hypotension, patient who is breathless, not corrected by the nasal cannula of oxygen, patient who is persistently hypoxic, patient who is bleeding, patient has rise or fall in hemoglobin beyond a critical level, patients with the oliguria or abnormal laboratory reports. Even if the patient has no bleeding, if the platelet counts are below 10,000 or platelet counts are regularly falling, I would definitely keep the patient in the hospital for next 2 days at least. So this is what we mean. If the patient is rising urea and creatinine, it's better we observe the patient in the hospital. Management, we would not be discussing in detail about the management, but as an OPD level, our management always is general and supportive, and specific management once we diagnose the case. So the specific general management is the antipyretic, where we strongly urge that use only paracetamol and not NSAIDs, ibuprofen or nimesulide or the other NSAIDs drugs. And hydration, we must insist with the patients about the hydration. Antiemetics may be given as a supportive treatment so that our medicines are retained. And symptomatic treatment in the form of the patient has dry cough, we might give cough suppression. This is all that we need. Antipyretics, we can give paracetamol, we can go right up to the 4 grams in adult. Not an issue unless the patient has chronic liver disease or alcoholic, then we might restrict to 2 grams of paracetamol in a day. Otherwise, we can give up to 4 grams of paracetamol without any fear of hepatotoxicity. What is important that, as I repeatedly emphasize, that we must avoid NSAIDs, antibiotics, and steroids in undiagnosed case. If you have diagnosed it and if it's required, that's a different story. Another important thing is, if the patient is not recovering on expected lines, we have thought of malaria or we have thought of dengue, and now it is 5th day patient is not responding, patient continues to have high-grade fever, something like that. Always think of co-infections or mixed infections, because that's what is not uncommon in this monsoon season. Patient may have dengue and chikungunya, patient may have dengue and malaria, patient may have viral fever, that is influenza-like illness and dengue. All combinations, we have seen it in practice. So if the patient is not responding, either there are some complications or there are co-infections, and we should investigate further. Coming to management of malaria, right, this is what WHO guidelines has practically remained same. If it is a Vivax, we give chloroquine for 3 days, and after getting the C6PD, we should give thiamacine for 14 days. Usually it's a 15 milligram BD for 14 days. If the patient is falciparum, generally we presume that it is chloroquine resistant at whatever area the patient might be. The best treatment if the patient is stable is artemisinin combination therapy for 3 days and a single dose of primaquine, something that probably is not followed routinely, but Primaquine is a gametocidal drug, so we are preventing the passage of falciparum to the community. So it's very important we complete the course and give primaquine a single dose, right? That is 45 milligrams. If the chloroquine is sensitive, we might give chloroquine, that is different. But otherwise, artemisinin combination therapy is the treatment of choice. And that is what is very important. Amongst the available artemisinin combination therapy, one which we use practically is the artemisinin lumefantrine. That is something which is now available, is a high strength dose. That is, that one tablet itself will have 80 milligrams of artemisinin and 480 milligrams of lumefantrine. So we can give 1 BD for 3 days. This is one drug which is better absorbed if we give it food. So that instruction also which we give to the patients, we give 1 BD for 3 days. If people have been using other combinations, but my preference personally would be the artemisinin lumefantrine. Easier, simple way of treating, and so far touchwood there have been hardly any resistance reported with this. We can use artesunate mefloquine also, right? Or the new combinations which are developed by our Indian government biopractice department is arterolen. Piperacin is available as Tinriam. I haven't used it, but it's also supposed to be very good. It's a 150 milligram of arterolen and piperacin of 150 milligram. The dose is simple, 1 daily for 3 days, 1 OD for 3 days. So artemisinin lumefantrine or arterolen, piperacin available same, one drug only, so Tinriam we can say. Very importantly, I want all of you to know that the government of India has come out with the National Center for Disease Control, has come out with the guidelines. And if we follow these guidelines, which are updated till the last, and what is important is we follow the national guidelines, which are developed by the experts and very experienced people. One, and second thing, if we follow the guidelines, then we can say that it is we are backed by the national guidelines. So if something happens, right, the case goes to the court, we can say that we have followed what is the standard care of, and that's very, very important. It's very important. And in that guidelines for sinusitis, it's clearly mentioned that most of the sinusitis, the 90% are viral. You don't need any treatment. If it is something like bacterial, because of the patients having some chronic sinusitis or predisposing diseases, then we might suspect the bacterial sinusitis if the patient has persistent fever beyond 6-7 days, patient has tender lymphadenopathy or throat which is painful, dysphagia. Maybe we give amoxicillin clavulinate as the first line of drug. Alternative is moxifloxacin. We should be giving for 7 days. That is for rhinosinusitis. Majority are viral. No antibiotics are required. That all we need to give as per the national guidelines, either amoxicillin clavulinate or moxifloxacin. Likewise, if there is gastroenteritis, majority are viral or food poisoning, where we don't need any antibiotics. What is important is only rehydration, oral or IV, depending on the patient's symptoms and tolerance orally. If it is cholera, 300 milligram of doxycycline, all that is advised, right? Or alternatively, or if the patient is a child, very young child, or a pregnant lady, we might give azithromycin 1 gram state. Or alternatively, ciprofloxacin 500 milligram twice a day for 3 days. All these guidelines are available free. We can download, keep it on our desktop or handy. I'm just giving you some idea about what these guidelines are. For bacillary dysentery, it is the ceftriaxone if patient has persistent vomiting or cannot take orally. Otherwise, cefixime can be given, or azithromycin is the second choice. If the patient has Campylobacter as the cause of bacillary dysentery, drug of choice would be azithromycin. Like what is important is in typhoid fever. We know that the gold standard had been in our days when I was a resident of chloramphenicol. Then came quinolone, and quinolone ruled the world for almost 10 years, we can say. But now we know that most of the typhoid fevers are resistant to nalidixic acid as the group and most of the quinolone. So better, as per the national guidelines also, we give cefixime. What is important that I want you to see, is it 20 milligram per kilogram or maximum of the highest dose is 1200 milligram of cefixime. There is no point in giving 200 milligram cefixime for 5 days and remain the sense of security for any infections. As far as typhoid is concerned, please give 400 milligram of cefixime 3 times a day or 600 milligram BD, and that too for 14 days. If you give azithromycin, 500 milligram BD for 7 days. This is what we should be prescribing. Alternatively, cotrimazole, we can give it as a double strength tablets of 2 BD for 14 days. So what is important is cefixime, 1200 milligram for 14 days is the drug for typhoid fever. If the patient needs hospitalization, third generation cephalosporin like ceftriaxone with without azithromycin should be given. Once the patient can be oral, we can switch over from ceftriaxone to cefixime again, but complete the course for at least 2 weeks. For leptospirosis, doxycycline remains the drug of choice. If not for any reasons like a very child, even the Indian Association Pediatricians have also confirmed that doxycycline can be given even in the pediatrics up to the dose of 2.2 milligram per kilogram body weight. So doxycycline remains the drug of choice for conditions where it is the first drug of choice. Alternatively, we can give amoxicillin clavulinate or azithromycin. Patients who need to be hospitalized, penicillin, cefotaxime, and the complications need to be taken care of. What is last part of it is the prevention of the diseases, where we have to take care of all the areas where we can prevent the transmission of the disease or waterlogging and the mosquito breeding. So whether it is that water stagnations or whether it's that we have to wash the hands or avoid pre-cut fruits and all dairy foods and all these things, we must eliminate the breeding site. We know that Anopheles and the Aedes aegypti have different breeding habits. One is in clear water, another is in stagnated water. So all the possible water places, whether it is overhead tanks or ponds or coconut cells, everything, or the water cooler, where we should be changing the water if it is a flower vase every 3 days. Then COVID appropriate behavior, we don't have to say much. We have had all this for years, 3 years. Now we must disinfect our hands and stethoscope. Only 2 minutes, please. We have to disinfect our hands and stethoscope before we asking for patients to use only disinfectants. It is really very, very hard to change the medical culture than the microbiological culture. We have to sadly accept this. Then prevent the preventable. Before the monsoon starts, one of the important things that we must practice to our patients and the relatives is vaccinate, and vaccinate. We must go for annual influenza vaccine, pneumococcal vaccine in most of the people, at least all above the age of 65, and all patients with any comorbid conditions over the age of 90 to go for pneumococcal vaccines. Typhoid vaccines, especially people who are staying in old age homes or hostels, and hepatitis B vaccine. So vaccination is another very important preventive measure. So lastly, we can say that our Prime Minister has been working very hard and dedicate 100 hours a year towards first join our worthy Prime Minister and Swachh Bharat, Swasth Bharat. Thank you very much for hearing. And if there are any questions, I am happy to answer these questions. Thank you all.
Thank you, Dr. Mahadev Desai. Kasundra sir. I think there is one question from one person.
Yes.
The use of caripil, that is carica papaya, is it useful in platelet to increase platelet or something like that, Mahadev Desai?
This question, first and foremost thing is that the IMA is strongly favoring avoiding the mixopathy. So this question doesn't belong to us. So in that context, I can say that we do not prescribe caripil. We should not be prescribing caripil because it's an allopathic drug. Having said that, the science behind caripil is that it is only the papaya leaf extract which is shown in some of the studies to increase the platelet count. But any drug that increases the platelet count doesn't become the drug of choice for the dengue or indication for dengue for the very simple reason that we have got drugs like L-trombopog and romiflostim, which is also for the platelet, increasing the platelets. But we do not use even these drugs for because the mechanism of thrombocytopenia in dengue is the platelet destruction one and injury to the endothelium. So endothelial dysfunction is one where raising the platelet count will not help. There's a platelet destruction. So if we give the platelets, we are adding fuel to the fire. So practically it's not going to help. That is why even in our medical treatment guidelines, there is no role of profiling of platelet transfusion. Only when the patient bleeds or when the platelet starts less than 10,000, we go for the platelet transfusion. So even the studies have shown few increase in the platelet count compared to the control when the caripils have been used as a research, even if it has appeared in our journals also. But I think it remains as an experimental drug therapy at the moment. And since we do not have the large studies and since it's not a part of our therapy, I would not go for it.
One more question from Dr. Arvind Panchal. So sometimes because of high-grade fever, when we give paracetamol in adequate dose, fever again increases after 2 to 3 hours. Is it preferable to give some paracetamol IV or some mefenamic or something like which is better?
See, very important questions. And see, if you waited a longer, see, temperature when it rises from the very low temperature, if you give paracetamol, it will go to say less than 94 degrees Fahrenheit also it goes. So if it is hypothermia and if it starts rising, patients will have high-grade fever, and the body ultimately is the hypothalamic center which is sent at a higher level because the body needs to produce more heat. That is why there is generation of the fever. Important thing is we can give paracetamol round the clock, number one. IV paracetamol again will not have effect for a longer period, but we can go up to 4 grams, as I said, number one. Mefenamic acid or ibuprofen we can give provided we are sure that we are not dealing with any dehydration, acute kidney injury, or patient has no such contraindications to use, or bleeding tendencies. Dengue fever, I would not give any of these NSAIDs. Otherwise, for malaria patients, if there is no renal doubt, we can give. There is no question of giving. But again, I am strongly against nimesulide. Ibuprofen would be fine. Mefenamic acid, we do not have much data about it. So I would prefer a drug which we know more about, either ibuprofen or diclofenac, but which has a shorter half-life compared to the others.
So one more question is, fortunately, we don't see lot many cases of malaria since last 3 to 4 years. But ingeniously, we were seeing a lot of cases of this malaria, and in particular P-Vivex. At the meeting, there was a controversy that if you give a primaquine to eradicate the malaria, but there is mosquitoes are there and is again going to bite, then what is the use of giving primaquine? So, will you suggest the rationale of using primaquine during season, or at what time we have to use primaquine?
See, as
during hematocyte,
it is not only the guidelines; it's a policy. It's a national policy. What I said is a policy. When it is a policy, if you don't use, you have failed on the part of giving the correct treatment. So somebody can challenge it otherwise. We have to prescribe because it's a part of the policy. There is policy. It's not, guidelines are just advisory. But here it is a part of the policy that we should be using it. So we have to use it. Only thing is that primaquine for falciparum is only single dose we give it. For Vivex, we have to use it to clear the hypnozoites because we have seen patients of Vivex, they keep on coming with the effects of malaria, huge spleen, anemia. So that is where we have to give the full dose. If we give it for a single course of 35 milligram of primaquine, that is 3 tablets of 15 milligram, I don't think that it is something, it is to clear the gematocidal drop. So I would be prescribing in all patients of falciparum after the course of ACT.
The one more question from Dr. Vinod Bhai. There is one prognostic marker for a platelet. Test is there.
It's a very good question.
Will you enumerate the test?
I think it's a very, very important question, at least in the doctors who are working in the major cities or metros, where now all our laboratories do the blood test, right, by automatic cell counters. And they do not manually count the blood cells, right? They do by automatic counters, and which are giving the idea depending on the size of the platelet. So if the automatic counter gives the picture what is called immature platelet factor, IPF, or mean platelet volume, MPV. If suppose that we have seen the patients, as Dr. Vinod Bhai said, we have seen the patients on the course of 5th day, and his platelets are say 30,000, 40,000. We are not sure, or maybe 20,000, and we are not sure we should be doing platelets. I would look for the IPF and MPV. If the IPF is high or MPV is high, mean platelet volume is high. What are these indicative? That bone marrow is producing the platelets. This is the peripheral destruction which is going on. If the bone marrow has not failed, this is one of the mechanisms for the thrombocytopenia, one of the contributing mechanisms. So if the IPF or MPV is there, I'm reasonably sure that patient is going to recover in the next 48 hours. So I would refrain from giving the platelets, because platelets, like blood, are the live product. We have seen platelets leading to acute transfusion-related lung injury, transfusion-related acute lung injury, patients requiring hospitalization, ventilation, pulse. So platelets, because platelets come from multiple donors. When we use platelet, 1 unit of platelet, it comes from many donors, and that give only 5,000 platelets price. So we need 4 or 5 platelet units. That will add to the number of donors. So the chances of transfusion-related problems are more with platelet than blood. And that is why platelets to be given only when it are injured. That is the very reason. So IPF and MPV is the answer. I just stated little few things more.
Thank you. Thank you. Yes,
Yes.
yes.
Yes, sir. Any role of steroid in hemorrhagic dengue?
Steroid has no role in any place of dengue, surely, sir. No.
Any question?
Jadeja Sahib is there or not?
Yeah,
Our
he's there.
president is there?
No contact.
Okay.
He's there.
He
Over
has
to
joined,
Kasundra.
sir. He has joined.
Huh?
I will be- I
You
can
know-
see him.
He is.
Jadeja Sahib, are you there? No, I don't think. I think he
He's
is left.
there.
Mahadev
he's
Desai
there.
Bapu.
He's
He
there.
is there, sir. He is there. He is there.
Jadeja Sahib, unmute करो.
Unmute करो.
Unmute करो. रुसिल तू अनम्यूट कर देना जाडेजा साहब ने.
Yeah.
Our president, the Gujarat State Branch President is with us. And we would like to hear a few words from him also.
Mehul Bhai is there.
No, Mehul bhai
Our
nathi.
secretary. No.
સાહેબ ને સંભળાતું નથી.
Mehul Bhai છે.
ના, મેહુલ ભાઈ નથી. મેહુલ ભાઈ ગયા.
I'm speaking something,
Yeah.
but probably they are not able to hear.
रुसिल तो जाडेजा साहब ने अनम्यूट करे.
Unmuted.
I think beeper जो इफेक्ट लागे. Okay. So what
Dr.
to
Mehul Bhai, yes,
Uh,
Bhai is live.
finish the formalities. I think Dhiren, now you can give us vote of thanks now.
Thank you so much, first of all, to Dr. Mahadev Desai for delivering the very excellent and exactly pertaining to our practice. And yes, I think covered each and every aspect of the monsoon sickness, what we are seeing day by day in our practice. And also thankful to our College of GP president. He has joined from Canada. I think there must be a night at this time. And
Yes,
he has
Ramesh
specifically
Babu.
invited my invitation and he has joined there. And thankful to President Dr. President GSB, Dr. Mahavir Singh, Secretary GSB, Dr. Mehul Bisha, and all other attendants, and Dr. Darbar Sahib, specifically for conducting very nicely this program. Thank you so much. Thanks to all of the office bearers and all the viewers who have attended this program very nicely in large numbers. Thank you so much. And we are hoping same response on the or better response on the next month. Thank you so much.
So our next webinar is on 13th of July. That is the second Thursday of July month. And it will be on the pulmonology. The topic will declare very soon. And thank you all for your attendance. Thank you.
Thank you so much.
Is there any changes just you put on our group? Definitely.
Yes,
Sure.
sure.
Okay.
Definitely.
Sure. Thank you,
Bye.
sir.
Thank you so much.
Very good. Okay.
Thank you. I enjoyed it.